Okay, so dear friends and colleagues, welcome to our webinar, which is being hosted by Turkish Menopoz and Osteoporosis Society. Tonight we will discuss the genitourinary syndrome of menopause, and also we will discuss the erbium YAG laser treatment. We have a distinguished guest. I'm announcing this guest in English because we have some guests outside the country. So first, Zdenko Vizintin has been working in laser in technology in Fotona for more than 40 years. And he is electronics engineer, and his current position is a director of medical laser program, and he is responsible from the applications development and clinical affairs, and he is researcher. He is expert lecturer for Laser and Health Academy, and he's gonna tell us actually, he's gonna introduce us erbium YAG laser and its application in gynecology, and also he will mention about safety issues. Our next speaker is Dr. Gambacciani, as a professor of obstetrics gynecology at the Department of OBGYN, Santa Chiara University Hospital, Pisa, Italy. He is a member of numerous national and international professional societies. He served as a member of executive committee of the International Menopause Society and of the European Menopause and Andropause Society. He is currently the secretary of Italian Menopause Society and the secretary and founder of Vaginal Erbium Laser Academy. Our last speaker is Ivan. Yes, Ivan is everywhere in Croatia. He is working at Rijeka University. He is working at the Department of Health Studies, University of Split, and he is working at University of Applied Health Science in Zagreb. He is a founder and board member of the Croatian Menopause Society, and senior lecturer at the Laser and Health Academy, Croatian representative in the Council of Affiliated Menopause Society of the International Menopause Society, advisory board member at European Menopause Society, and he is going to tell us the erbium YAG laser applications in urinary symptoms. So, before going through I would like to remind you, we will get the questions at the end of the sessions, whole sessions. So if you want to ask any question, please write or text at the Q&A button. And also, I would like to notice you can use the interpretation button by selecting the Turkish, so you can hear in Turkish. Before that, I would like to share my screen. Okay. Okay. Before progressing the program, I would like to give a brief summary regarding the genitourinary syndrome of menopause. Whoops. Okay, genitourinary syndrome of menopause describes the symptoms and signs resulting from the effect of estrogen deficiency on the female genitourinary tract, and symptoms associated with GSM are highly prevalent among the postmenopausal women and also it can significantly impair the health, sexual function, and quality of life. The most commonly reported symptoms by the patients includes irritation of the vulva, inadequate vaginal lubrication, burning, dysuria, urgency, incontinence, all types of incontinence actually, dyspareunia, vaginal discharge, sexual dysfunction. And most commonly reported signs by the clinicians are labial atrophy, vaginal dryness, introital stenosis, which is commonly associated with changes on the vulva, such as clitoral atrophy, phimosis, hypopigmented area on the vulva, and petechial bleeding, ulceration, tears in the vaginal surface, and rectal caruncle prolapse and polyps. There are mainly two surveys which measure the adverse effects of genitourinary syndrome of menopause on postmenopausal women. One is the vaginal health inside and view attitudes. This survey actually, online survey actually includes 3,500 postmenopausal women, and they reported that the symptoms of genitourinary syndrome of menopause had a negative effect on their lives and had adverse effects on sexual intimacy. The woman reported that they felt less sexual and felt old. Also, they reported negative consequences on marriage relationships and negative effects. And consequently, they had a lower quality of life. The other study also pointed out the same results. And the woman detract themselves from enjoyment of sex, and also these symptoms led them to loss of intimacy. We usually evaluate the patients by applying some questionnaires, usually addressing to the specific symptoms. And also, this questionnaire is necessary to determine the severity of the symptoms, also to determine the efficacy of treatment. The most bearing symptoms should be determined. Also, during the pelvic exam, we should easily determine the vaginal maturation index and vaginal pH. We have options in the treatment. The treatment options include lifestyle changes, lubricants and moisturizers. Vaginal estrogen, of course, it is the gold standard to start the treatment, but we can't use the vaginal estrogen is contraindicated for women with history of breast cancer, ospemifene, vaginal DHAA, and topical testosterone cream, but the last one is not established treatment of choice. So before passing the word on to Zdenko, I would like to announce our next two webinar. The first webinar includes the history in menopause, and the other webinar will be regarding the menopausal terminology and the tests and the climacteric symptoms. So the turn is yours, Zdenko.
Thank you very much, Tamer. I'm just checking if I can share the screen, which I'm not able to. So please give me the right to share the screen. Okay, great. So once again, good evening to everyone. My name is Zdenko Vizintin, coming from Slovenia, Ljubljana, and today I will be talking to you about erbium YAG laser for gynecologists. and also about safety issues. So all of you heard about laser and probably also know about some lasers, and I'm sure some of you also use some lasers. But laser becomes so common word that a lot of people does not know that this is actually an abbreviation of this sentence, light amplification by stimulated emission of radiation. And when we talk about light, what we have in mind is this part of visible spectrum, what we can see. But in fact, there are many lasers working in infrared invisible region. On this graph, you can see the spectrum, electromagnetic spectrum, different wavelengths, and these are the abbreviations and wavelengths of many, many, many lasers used in medicine. Among these lasers, we will be talking today mostly about erbium YAG laser, which is emitting on this particular wavelength, 2940 nanometers. Why we go after erbium YAG and not after some other laser? There is a very strong reason for this, and this is that this particular wavelength is the best absorbed laser wavelength in the water. Here on this graph, you can see the curve of absorption in water, and erbium laser is by chance sitting on this very peak. So it's the best absorbed laser in the water. And there are also some physical features which are enabling this laser to achieve vaporization of the molecules of water inside the tissue with a minimal quantity of energy. So it is excellently fitting the water molecule vibration, which is an inherent feature of these molecules. With this laser, we can work in so-called ablative mode, where we are removing the tissue. We can have a combined mode when we are removing the tissue, but also warming up the tissue. Or in our particular laser, we can work also in so-called non-ablative mode, where we are just doing warming and coagulation. When we are talking about ablation, we can drill the holes in the skin very deeply in the tissue, in the bones, in many materials. So it is not a problem of depth. Usually we are working in the first millimeter of the tissue, but on this picture you can see 3 millimeter deep hole, which was drilled by vaporization of this tissue with erbium YAG laser. When we are looking into optical penetration of various lasers in the medical use, you can see on this graph different lasers, including, for example, neodymium YAG, 1064 nanometer, which is penetrating the deepest. And then on this edge, we can see erbium YAG and also CO2 lasers, which are both very shallow in their optical penetration. And one thing which you have to remember is that the depth of optical penetration depth is absorption dependent. So how these wavelengths are absorbed in different chromophores, among which the water is one of the most important. So of all of these lasers, erbium YAG is the best absorbed in water. And then if you look into these two modalities of use, one is non-ablative use, where the laser beam is just spreading into tissue, producing some warming, or when we are drilling the holes to remove some tissue or to make some microscopic wound with the fractional beams. You can see that, for example, in these two lasers, although there is some slight difference in optical penetration, if we are looking ablative mode, they are practically the same in possibilities how deep to drill. But what we are using, in fact, in gynecology in the last 10 years, mostly, is this third mode, which is quite specific. It was developed by Fotona. It's also patented. And we call it Fotona'nın smooth erbium YAG mode, where we are producing a thermal processing of the tissue. And the spreading of this energy is by heat diffusion. It's not optical penetration. It's not drilling the hole. It's a heat diffusion. And it can be very well controlled. So this is just for your idea how this smooth mode looks like. We have a series of micropulses, which can be delivered either in a fractional way or as a full spot. And then the temperature on the surface and also in depth is following this sequence of micropulses. When every next micropulse comes, the heat is pushed deeper and deeper. And then we are also using a series or bursts of such pulses to deliver the heat at exact value. So temperatures which we want to achieve for our vaginal treatments are around 65 degrees on the surface of mucosa. The mechanism of action, how we are actually helping in the gynecological indications like GSM or stress urinary incontinence, can be explained in several aspects. This particular laser has multiple mechanisms of action. Here, I will show you just briefly. You don't need to go here in detail. Just briefly, that there is two components, two thermal components of this laser. One is quick and fast, and the other is slow and lower with temperature. So we can call them fast and slow. And if we are looking in this slow, which was known for a long time, effect of this slow thermal processing is consists of these three components: photothermal interaction, thermomechanical interaction, and then neocollagenesis, or growth of new collagen fibers. So on this picture, I'm trying to explain this. So when we are irradiating, this is a cross-section of vaginal wall with all the layers, starting with the epithelium, lamina propria, muscularis, and so on. When we irradiate the surface of mucosa, the heat is penetrating through epithelium into lamina propria. The depth is about 0.5 millimeter, so 500 microns. And what is happening on temperatures in between 45 degrees centigrade and 65 degrees centigrade is collagen remodeling, which means a shrinking of collagen fibers. You will get the shrinking of this, and the shrinking on the surface will also pull the lower laying layers of the mucosa, vaginal mucosa, and this is this photomechanical effect. And then through time, this picture is like 3 to 6 months after, there will be more collagen fibers because of the process of neocollagenesis, which was started by hyperthermia here. How it looks clinically, you can see here one prolapse. This is a cystocele, prolapsed anterior wall before the treatment. And here, 3 months after 2 sessions, you can see all of these effects of shrinkage. You get ruga back, and also on palpation, if you touch it, you can see that it's much more firm and thick. When we are treating atrophic vaginal canals, we are using lower intensities here, not such high temperatures. The temperature is around 45 to 50 degrees. And then the major mechanism of action is regeneration of the tissue through the neoangiogenesis. So there is a photothermal effect which is causing the increase of this vascular growth factor, and through them improvement of vascularities and generating of some new vascular vessels. All of these effects we were able to prove also through histological pictures. Regarding this fast component of heating, we just discovered it some 10 years ago. It's relatively new, but what does it doing? This micropulses is causing a very high peaks of temperature, but very short one, which are not painful, which actually do not cause vaporization. They just cause a thermal stress. And this thermal stress is then working through this keratinocyte paracrine signaling. It's a quite complex process, but in fact, it is contributing to the overall result in a rejuvenation of the vaginal mucosa tissue. If someone is interested to learn more about this, there are 2 articles. They have open access, both of them. You can take a look into them and read about the mechanism of action of erbium YAG to the human tissue. We found through time that not only us, but also the other investigators found out that erbium YAG has some really nice healing capabilities. Just for your information, there's a few articles talking about healing power of erbium YAG, and they were used in other applications. But if you're also interested about these topics, you can just search the internet and you find how nice this wavelength is. This is why we are preferring. On top of that, it's very safe. So moving on from this, let's say, theoretical introduction to technology, this is a laser. We call it Photona Smooth or Dynamis. It can consist of 2 wavelengths or just 1. And the tools which we are using to treat vaginal canal consist of some pieces which we call the laser speculum, and then some adapters which are bringing the laser beam into the vaginal canal. At the beginning, we were using this kind of metallic set, but now we have also a glass one, which is more practical and easier to use. And by time, we developed also the robotic probe. It's a scanner which is doing the whole procedure just by pressing the button, and it eases the work for the user. Also, it is standardized the protocol, so it is eliminating the human errors, and it's become very popular since its introduction in 2015. Lastly, we developed this intraurethral handpiece, or we call it also cannula, for treatment of sphincter, of intraurethral treatment for both indications like intrinsic sphincter deficiency in stress urinary incontinence, as well as urinary issues in GSM. It works very nicely, it's very gentle, you don't need even any anesthesia to introduce it, and it is producing here the temperatures of about 45 to 50 degrees without causing any problems. So altogether, the tools consist of different accessories. Some people has just a manual set, some people has a robotic probe, and all of them now are getting also the intraurethral probe for these specific applications. Going to the applications, we started with two major indication groups: pelvic floor dysfunction and genitourinary syndrome of menopause, and now it's already 10 years that we were working in this field. If we are looking into GSM, what we treat there, we treat, of course, vulvovaginal atrophy, we treat urinary symptoms, and also sexual dysfunction connected with it. In pelvic floor dysfunction, we are talking about urinary incontinence, and here Fotona and this laser is really very specific, or I would say superior to anything else on the market. We can treat all types of incontinence, not just stress urinary incontinence, but also overactive bladder, mixed incontinence, and even with this cannula, we can treat also intrinsic sphincter deficiency issue. Then we have also studies and good results, and also certification for treatment of pelvic organ prolapses, especially cystocele and rectocele. Then vaginal relaxation syndrome or vaginal laxity for sexual dysfunction. These three protocols got also the commercial names like incontilase, prolaplase, intimalase. And then also we have works and studies in the field of anal or fecal incontinence, and also here in vulvar issues like pain due to vulvodynia or episiotomy-related complaints. After these two first major, I would say, big indications, through time, we get excellent feedbacks and results from other fields in gynecology. Specifically, a lot of people are using laser also in aesthetic gynecology, but there are a group of applications in chronic infections and also many other indications in gynecology. So just a brief look into it. I will not go into details. My colleagues after me will be talking about applications more in details. Just to mention, in the field of chronic infections, we have studies which are showing efficiency and safety of this laser for different bacterial issues like candidiasis and some other infections, and also urinary tract infections. The studies are showing excellent improvement. When we are talking about aesthetic gynecology, one of the biggest indication is labioplasty. A lot of people are doing this, and you can do this in this laser using erbium YAG in a surgical mode, in surgical ablative mode. Then treatment of various scars to improve the scars visually, but also to improve the functionality and to relieve the complaints and pain. Then vulvar whitening and vulvar tightening are also aesthetic applications. Here we have very nice results. Vulvar hair removal, although it looks very banal, is quite sometimes sought by the customers. And then also some removal of excessive fat in the mons pubis and vulvar region. These are all aesthetic applications which our users are doing. When I'm talking about other gynecology, on the first place here, I can say that we have excellent results in treatment of lichen sclerosis. There are 2 publications, even one of them is randomized controlled trial showing the efficacy of this laser. Removal of condyloma is very long time already in the use by surgical removal. We have treatments in different vulvar neoplasias. And just recently, the publication from Italian Dr. Ghilardi came out maybe 2 months ago. Removal of different cervical lesions connected with human papillomavirus, and then with the other valent neodymium YAG surgery, we can do myomectomy, different intrauterine problems, and also other surgical interventions where the laser is used instead of the scalpel. The advantage of laser is, in comparison, for example, with radio frequency, that laser can do work also in liquids. There is no conductivity of light, so it has its place as well. And last part of my presentation will be clinical evidence of efficacy and safety of this laser. There are many publications in the period of past 10 years for all of this application which I mentioned just earlier. I don't have time to go through all of them, but they are proving efficacy and safety with the use of many different tools. So altogether in this moment, I can say that in all of these journals, there are more than 70 clinical studies and papers published in the past 10 years. If we look just into the GSM, there was 15 clinical studies published with this laser, in which more than 1,600 patients were included in these studies. Different objective and subjective tools were used. You can see here maturation value, pH, histology, different visual analog scales of symptoms, and so on. All of the studies showed significant improvement in large majority of patients, and with the duration of the effect at least 12 months, in some patients even longer. And this particular application is specifically beneficial for the patients which are not able to use hormonal therapies, like breast cancer survivors. I already mentioned that this laser is very good for all sorts of female urinary incontinence. So far in 10 years, 36 clinical studies were published with more than 2,000 patients. And in these studies, people were treated for SUI mostly, but also for MUI, ISD, and overactive bladder. All sorts of objective and subjective tools were used. My colleagues will talk more in detail about it. And in summary, whichever measurement tool was used, between 75 and 90% of patients were significantly improved. And the effect was lasting again at least 12 months, and in some patients even longer. In spite of that, there is still a lot of skepticism about these new methods. This is just one example from TV show in US where they are like doubting that laser can fix incontinence. The similar thing you can find in some surveys which start to came out somewhere in 2016, 17, and were analyzing what was published until then. So there was critical appraisal and so on. But in 2018, what happened, some of you maybe learned, it was a warning of FDA that these energy-based devices, not only lasers, but also other energy-based devices like radio frequency devices and ultrasound devices, were not yet approved by FDA for these particular applications. And they based their warning, they based on some very small number of side effects, which was detected in so-called MOD base. MOD database is a US database where people are reporting the side effects. And in this article, which was published after this warning, you can see that in period of 4 years, there was a relatively small number of events described in just 46 patients, and patient-related injuries were just 39. So in the period of 4 years, with many thousands of procedures done. If we compare, okay, let's see what were these side effects. All of these side effects are very mild and transient. practically none of this adverse effect required any intervention. It was just a period of time to pass for them to fade. On the same time, if you are looking into the same MOD report for about similar period of about 5 years here, you can see that in this search, almost 4,000 reports of injury, even death and malfunction was given for the devices which are FDA approved, like for example, urogynecological surgical mesh products. And this is also the reason that later by time, some of these products were actually banned, not only in US, but also in UK and some other countries. So what I want to say here is that these two things are not comparable in a level of the side effects which are reported by users and also by patients. This is why the Vaginal Erbium Laser Academy issued this safety communication after the warning. And in this communication, they said that what they find out from the studies which were performed until 2018 is that this laser produces effective, non-invasive procedure and safe treatment for GSM and SUI. And that it actually improves the quality of life of patients which don't have other choices. So in last 2 years, a lot of new studies were published and also much more users appear on the market. So just recently, this was, I believe, September 2020, this paper came out in American Journal of Menopause, in which the authors, this is a group of American authors, actually they stated that FDA safety communication appears unsubstantiated, and that well-documented benefits and low risk of adverse effects suggest that laser therapy for GSM is reasonable with appropriate pretreatment counsel. So they were criticizing the FDA safety communication as non-substantiated with evidence. Very quickly after that, I believe it was October last year, the other publication came out, and this is from American Urogynecology Society. It is called Clinical Consensus Statement. So a large group of clinicians were giving their opinion. And the findings, efficacy outcomes, what they said is that these two lasers, erbium YAG as well, have shown promise in treatment of vulvovaginal atrophy, vaginal dryness, menopausal dyspareunia with benefits lasting up to 1 year. And based on data, it seems that it has favorable safety profile and so on. Also, this is an Italian Society for Menopause, which recognized the laser therapy as valid one for GSM, and you can see in their guidelines, and these were the latest guidelines in 2019, they introduced laser therapy as one of possibilities to treat GSM. Lastly, this is a slide from last year ICS Congress. It was in December, just 4 months ago. I believe a lot of you recognize this lady. This is Professor Linda Cardozo from UK. She had a lecture about what is the role of laser therapy in genitourinary syndrome of menopause. And her conclusions, among other things, said that there is sufficient and growing robust data on the use of laser for treatment of GSM. Laser is efficacious and long-lasting, as well as the other treatments, and laser is now being offered as the first-line treatment for patients of GSM. I remember my first meeting with this professor in 2014. She was very skeptical about laser, but since then she started using it, also participated in a big study, which we will publish soon. And as you can see, she started actually to promote this laser. We certified these protocols like vaginal relaxation syndrome, stress urinary incontinence, genitourinary syndrome of menopause, and pelvic organ prolapses, starting already in 2012. And not only in European Union, we got certifications in Australia, in Singapore, in Canada, in Taiwan, and also some other countries. So I would say in majority of the world, it's legal, it's certified, and people can use it. Lastly, last few minutes, I will dedicate to the safety of this particular laser, not in general of all lasers. Our first review of the safety was done in 2014 on the 6 medical sites and a relatively small number of patients, less than 1,000. But still what we find out is that all the side effects we found are mild and transient. Edema was present because of hyperthermia of tissue. pain during the treatment because we don't use anesthesia, and then some superficial burns, which are error of the users, some bleeding in pinpoint bleeding, very quickly healed in a atrophic patient, some stronger vaginal discharge, again, as a consequence of edema. And the only thing which a little bit surprised me was this, the no urge incontinence, but I later learned from literature it's quite common after, for example, sling procedure for SUI as well. So everything what we found was mild, transient, and benign. The next survey we did in 2016, based on 31 published articles, and the situation was quite similar. So you can see here side effects relatively small, the percentage are very low. It's very safe procedure. And then provoked by this FDA statement in 2018, Vela Academy started a global survey of safety of vaginal erbium laser, which was performed among active users of this laser around the world. The questionnaire was distributed electronically to the active users in 70 countries all around the world. And when we got the feedback, it was quite large. The response, there were 535 clinics from 43 countries responding about the issues with 113,000 patients. So it's a huge numerous, and this is what they reported. So you can see here this top adverse effect reported: vaginal discharge, edema, pain during treatment, pinpoint bleeding are the same as we are noticing already 6, 7, 8 years ago. Percentage overall frequency is quite small. And then some other things which they reported, like itching, dryness, and no-urge incontinence, and so on, are very small frequencies here. So again, all the observed adverse effects were mild and transient. And most of the practitioners did not consider this fourth adverse effect as a fourth adverse effect at all. They expect to get this kind of effects after hyperthermia of vaginal mucosa. In the same questionnaire, we were also asking about the effectiveness, how satisfied the patient, and so on. And you can see here quite high percentages. Overall, more than 80% of patients is very satisfied with protocols, and they are getting a huge, significant improvement of their indications. This report is published. It was just published in October last year, and it's a free access. You can take a look into it and read it if you're interested. So to conclude my talk, non-ablative vaginal laser treatment for GSM and SUI is well supported by clinical evidence. And this laser is very efficacious and extremely safe for vaginal treatments. Thank you very much for your attention.
So, thank you, Zdenko. We will get the questions at the end of the session. And Marco, your turn.
Okay.
Are you ready?
I'm ready. Thank you very much, Tamer, for your invitation, and it's a pleasure to share the podium with you. Are you seeing my slides?
Yes.
Okay.
Very clearly.
My task today is to discuss with you the use of erbium YAG laser on the vulvovaginal atrophy and sexuality. And I don't have disclosure to be done, and I will follow the presentation of Professor Erel that already said that the GSM, the genitourinary syndrome of menopause, is a very big issue for the quality of life of postmenopausal women, because the symptoms of genitourinary syndrome of menopause, the genital symptoms, the sexual symptoms, the urinary symptoms can really jeopardize the quality of life of postmenopausal women. We do have a lot of treatments from non-hormonal, hormonal treatments, systemic and local treatments of spimifene, the prosterone, the DHA. But today we do have also the vaginal erbium smooth laser. And I'd like to discuss with you the issue, is the vaginal laser an evidence-based medicine option? And Zdenko Vizintin already presented some data, but I'd like to discuss with you, dear friends, my own procedures. I would like to to focus that all the procedures you'll be seeing probably reported in my slides are obtained with the company validated procedures. All the parameters are preset in order to minimize the intra and interoperator variations. That's why, as the Vaginal Erbium Laser Academy, with my colleagues and friends Tamer Erel and Ivan Fistonic, we were able in the VELA to put together all our data and to publish very interesting results in hysterectomized women, in women without hysterectomy, just because the same procedures done in Zagreb, in Istanbul, and in Pisa are the same, because the company validated procedures are based on preset parameters. So the techniques are really reproducible and appropriate for multicentric studies. And not to mention the Genitourinary robotic probe. The Genitourinary robotic probe make everything even easier with all automated procedures. As Zdenko Vizintin said, now we do have 9 years of minimally invasive non-abortive erbium YAG laser therapy in gynecology. And we do have a lot of very well done papers published in international journals, in peer-reviewed international journals. And as Vaginal Erbium Laser Academy, thanks to the support of the pioneer like Ivan Fistonic, Adrian Gaspar, Jorge Gaviria, and Tamer Erel, we were able to have different meetings, and we started the meetings in Pisa some years ago. Sorry for going, I will do, okay. Sorry, okay. We started in 2015, 16, 17, 18, and we had the last meeting in Florence in November 2019. And as Zdenko said, the proceedings of these meetings, are published on Climateric, the official journal of the International Menopause Society. And please, dear colleagues, take into consideration this is a peculiar proceedings because all the papers published are peer-reviewed. So all the proceedings, all these papers were peer-reviewed by anonymous reviewers, and therefore the validation of these data are very robust. For those that are not familiar with our techniques, I will say that the Renovalase, the protocol for GSM, for the vulvovaginal atrophy, is a two-step protocol. The first step, we do treat with a full beam all the vagina with a 360 degrees conic adapter. And the second step, with the pattern beam, we treat the introitus, the vestibulum. We do promote the photothermal effect with the vasodilation and an increased neocollagenesis. All the data you see, dear colleagues, are the data obtained with a 3 different sessions, 30-40 days apart. We do use, as Zdenko said, the glass speculum nowadays. This is very gentle, and we do introduce the probe inside the speculum, and it is very gentle procedure for the women. They don't feel the probe going back and forth. That is not going to be a very pleasant in an atrophic vagina, the probe going back and forth, and therefore the speculum is very helpful for making very patient-friendly all the procedure. You see, the glass speculum goes inside the vagina, and we work inside the speculum, even with the manual procedure or with the robotic procedure. I'd like to share with you our first data on signs and symptoms of GSM. And as you see, dear colleagues, with L1, L2, L3 are the 3 different laser treatments done 30-40 days apart. And you see the effects in terms of dryness, dyspareunia in the first 105 patients we treated. And you see the decrease of the visual score in 10-point scale. You see here the 60-70% reduction of the symptoms. And this was parallel to an increase in the vaginal health in the score. You see here the increase of the score from 11 up to 2022. And I remind you that 15 is the limit for the diagnosis of vaginal atrophy. And you see that just after one treatment, after one laser treatment, you are able to reduce the discomfort of our patients. But the question is, how can we compare the vaginal erbium laser effects with the standard treatments, and how long our results can last? And in the 2019, we published a 2 years follow-up study in 200 patients treated with the vaginal erbium laser. And once again, you see here that after the L1, laser 2, and laser 3, you see the decrease in the vaginal dryness and the patient dyspareunia. But we compare these effects with the women treated with local treatments, mainly local estriol treatments. And you see when you compare the first 3 months, the effects on dryness and dyspareunia of both local treatments, mainly estriol, and the vaginal erbium laser are superimposable. But when the women per protocol stopped the vaginal estriol treatment, after 3 and 6 months, you see that both dryness and the dyspareunia were increasing in those women that were treated just with estriol and not with the laser. While the women that were treated with 3 sessions of laser, they maintain a significant reduction of dryness and dyspareunia up to 12 months. While after 18 and 24 months, the women, they were showing an increase in the score of both dryness and dyspareunia. So, dear colleagues, this observational, that is not randomized, but it's an observational study, can give us the opportunity during our counseling with our patient before treating them to say, yes, with the 3 laser treatments, we can predict a 12 months effectiveness. And in fact, you see that out of 205 women, 84% of the women asked to repeat the treatment, mainly after 12, 18 months. You see 62 repeated the treatment after 12 months, 55 repeated the treatment after 18 months, 34 after 24 months. So only 5 women out of 205 were happy 2 years after the last laser application. The vast majority of them, they repeated the treatment after 12, 18 months. And please remind that all those women, they were just treated with the erbium laser. But we can improve also the sexuality in postmenopausal women. And our first reaction with the first data, they were saying yes. You know, these are women. They were treated after breast cancer treatments. The vast majority of those women, they were taking aromatase inhibitors, and you see the effects of vaginal erbium laser L1, L2, L3 on the female sexual distress scale. And I remind you that 11 effectively discriminates between women with a female sexual dysfunction and women without FSD. And you see once again that there is a decrease in the FSDS that is maintained up to 12 months. But you can say, dear colleagues, 29 women are not enough to demonstrate anything. And for that, the Vaginal Erbium Laser Academy is of help. You see, we collected data on 47 Italian centers, almost 1,300 questionnaires, and these are the data obtained in 554 patients in terms of FSDS. And you see the effects are there. And please consider that this is a huge number of women included in the next sexuality study. 554 patients included in the sexuality study, showing an improvement in sexuality in women treated just after the vaginal erbium laser. These are the results of an Italian large multicentric prospective study. The same apply for the FSFAI, 569 patients with 569 FSFAI domain scores. You see the total score 15, that is improved up to 27 after the treatments, and the effects are maintained for 6 months. So you see the effects are very impressive in terms of sexuality improvement. So in terms of the effectiveness of GSM, we can say that these data are really encouraging for the use of laser in the treatment of GSM in postmenopausal women. And as the Italian Menopause Society, as Zdenko says, we included the laser therapy in the different options we do have in the integrated management of postmenopausal vulvovaginal atrophy. I won't say that the vaginal erbium smooth laser is the sole, unique, but definitely is something that we must take into consideration along with the local estrogen replacement therapy or spimifene, prasterone, and even systemic hormonal treatments. So, but like George Clooney says, erbium, what else? Do the gynae need something else? I should say, never say, I don't need anything else, because we always need something else. And I would like to point out to your attention also one of the more difficult things to be treated, that is superficial dyspareunia, the pain at the vaginal opening during intercourse. That is a very common complaint in postmenopausal women, and not only in postmenopausal women, but also in women after vaginal deliveries with episiotomy scars and so on and so forth. And there are, the consensus is that we don't have a consensus on treatment. Do you see? These are the publication on the Canadian Medical Journal. You see the superficial dyspareunia can appear in the hypoestrogenic states after candidiasis, after lichen sclerosis, in the female genital cutting, obstetrical, and we do need effective treatments. You see, these are 3 different patients with a posterior commissural atrophy. Women after younger, she's a 50-year-old woman after chronic infection, on an older women with a lichen and the postpartum scars, you know, after menopause, both lichen and postpartum scars, a nightmare. And for that, for those lesions, we started using the combination of erbium and neodymium. The combination of what both wavelength enables a large number of various applications, as Zdenko says. And to make a very long story short, I'd like to show you this Fotona procedure for face lifting, nothing to do with the gynae, with the gynecology. But you see, pairing together the smooth procedure with the erbium and different mode of delivering neodymium with the refractory and piano, and the light peel with the superficial smooth, non-smooth mode with the erbium. We do have the Fotona for the face, non-invasive face lifting, and we did something very similar for the vulva, pairing both the erbium and neodymium on the vulva, mainly to treat the posterior commissura in order to improve neocollagenesis with both erbium and neodymium. And you see, we don't need much treatment before and after, but the results are astonishing. You see, this is the visionology score with Renovalase. I mean, just the erbium on superficial dyspareunia, just asking the women about the superficial dyspareunia. And you see here, the erbium is working very well. It reduces the superficial dyspareunia. But when you do the Gyne-4D, I mean, when you put together erbium and neodymium, the effects are much more evident. You see here the effects on the visionology score in women treated with the erbium and neodymium in the same session. And you see that these each time points are significantly different to each other, suggesting that the Gyne-4D is much more efficient in terms of superficial dyspareunia than the erbium alone. So the studies, we do have a lot of studies. Thanks to Tamer and thanks to Ivan, we did put together our data. We did some studies in hysterectomized women, non-hysterectomized women, and now we too are facing a new option in gynecology to put together the erbium and neodymium in order to treat women that are more resistant to the erbium alone. We do have a really a huge possibilities. We have a lot of possibilities to treat with the Gyne-4D our postmenopausal women. We do have ongoing clinical protocols to collect information in large database, providing solid evidence on vulvar score, visionology scores, DFSDS, before, after 3 treatments, and with a follow-up at 3 and 6 months. We do need to understand that the severe cases cannot be treated with just with one mode. We do need to integrate hormones, hyaluronic acids, and our dual wavelength with the neodymium and the erbium. And for that, this is a new challenge for the Vela family that I'd like to underline, that is the biggest gynecological laser community in the world. And for that, we thank Fotona for the unrestricted support for our studies. Thank you, Tamer, for your invitation once again. Thank you.
Thank you, Marco, for such a nice presentation. It was excellent. So we're a little bit behind the time. So Ivan, hello.
Hello. Good evening to everybody. Good evening, Turkey. Good evening, Europe. So thank you very much again.
Finally, the turn is yours.
Yeah, thank you very much for the opportunity to present here my opinion and my expertise in the erbium YAG laser treatment of urinary incontinence, which is one of the most embarrassing conditions in women's life, since not only sexual gratification is reducing, but also this embarrassment totally makes woman's life. Urinary incontinence affects about maybe 40% of women of all ages, but especially in nursing homes, this comes up to 60%. And most cause of this is trauma from birth, from vaginal birth trauma, which causes urinary incontinence, which we call stress urinary incontinence. But how the life is going on, we have the problem when the woman enters menopause, and where the deprivation of the levels of the estrogen will induce overactivity of bladder and will add to the problem of stress urinary incontinence. So how to cope with this? All international societies that are dealing with incontinence do prefer and do recommend conservative approach, which is on the first level. So when we have a patient with urinary incontinence, we should start with conservative mode. So here is a long broad fan of methods which are non-invasive, from behavioral methods, electrostimulation, etc., etc. If you want to start with something which is conservative, and we are, let's say, dealing with stress urinary incontinence, estrogen would not help. But some of the antidepressants, which is duloxetine, has a complex pharmacological effect that produce marked systemic anticholinergic action, which will reduce overactivity of bladder, but also, which is has been recognized by European Medical Agency, and it has indication in Europe also for treating of stress urinary incontinence, because it will enhance the effect of serotonin and noradrenaline for sphincter, for abdominal sphincter. But unfortunately, these articles that came out are of short follow-up, and also only 3 months, and also the problem is with side effects that duloxetine produces. Kegel exercises is the best. But of course, compliance is very low, because after 2 or 3 days of pelvic floor muscle training, a lady has another important things to do. Recently, Fotona launched this one comfortable possibility to treat urinary incontinence, which is called the Intima Wave. And this is, in fact, high-intensity Tesla magnetic stimulation of pelvic floor muscles that can stimulate muscle contraction in the entire pelvic floor area. Clinical studies are going on, and we are hardly waiting results from these studies. And 10 years ago, laser came on the field of conservative treating, non-invasive treating of urinary incontinence. First lady entered the study on September 1st, 2010. It is, in the meantime, more patients were enrolled in clinical studies, which are proving that the evidence that non-ablative and non-invasive area laser treatment is an effective intervention for urinary incontinence. Zdenko explained you the mode of the action, but the fact is that rising the temperature on the surface of vaginal mucosa will retract the collagen for 1/3, and it will also produce neocollagenesis, which can be easily seen on this slide, before and after. Here we can see after erbium smooth laser treatment, it is marked production of new fibroblasts, which means new collagen. And on this slide, histological study, you can see situation before and after. There is something new here that you can see here, these holes, which means that this temperature will dilate the capillaries and will promote also neovascularization and better trophism in this area. So I will, just for slight illustration, this is the first study that was published on erbium laser treatment of stress urinary incontinence. It was published in 2015, where we showed that reduction of incontinence is really significant in 12 months follow-up. So we reduced in median for 50% this incontinence, stress urinary incontinence. On this slide, you can see situation before, where all women were incontinent, mild, moderate, severe, or very severe. After the treatment, we have these blue fields that means that they are totally dry here. They are continent at all. And all of these other levels of incontinence reduced. So 72% of patients were experienced improvement. Some of the authors argued that there are no RCTs, no randomized control studies, which is wrong, because first study, randomized control study, was published from Solini and colleagues 2 years ago, showing that incontinence versus sham, this is a laser, this is sham, is markedly reduced if we compare it with the sham. Also, sexual gratification arises with the laser treatment. And for your information, huge clinical randomized control studies are going on in United Kingdom, Vesper studies 1 and 2, dealing with SUI and pelvic organ prolapse, and also on the King's College first head-to-head study between CO2 laser versus erbium YAG lasers. And of course, we are also hardly waiting to hear from the results. How else we can we prove to enhance the pelvic floor strength? We used also this gadget, which is called perineometer, and we were measuring the tightness of a vaginal wall. So we showed in 12 months follow-up that the vaginal tightness improved through the time. Also, you are very well aware that the Q-tip elevation is a mark of a pelvic floor disability. So after the erbium YAG laser treatment, we reduced the angle of a Q-tip, and also we showed the results in 12 months follow-up. We also use very simple method, which is measuring of post-void residual volume before and after. We showed also in 12 months follow-up that we reduced the post-void residual urine. And what mentioned also Tamer and what mentioned Marko, co-authors with myself in this study, all of you are aware that hysterectomized women are 4.4 times more likely to have a subsequent surgery for incontinence. So our question was, can we help to the lady who was hysterectomized to conservatively enhance her ability to stop unwillingly voiding? And we showed that it is possible, because all hysterectomized women and non-hysterectomized women, even those who have already implanted TVT or TOT, showed marked reduction of incontinence for 85% reduction. So we can easily use this method in hysterectomized women before any other operation, and also to the women who have implanted TOT or TVT. So take-home message from this study was that in hysterectomized women, this is a tip, in fact, more sessions will produce a better result. So we can use this in hysterectomized women as well as a good conservative method of reducing incontinence. Zdenko mentioned also recently introduced device from Fotona. When we have non-responders for erbium vaginal laser, which are, let's say, about 15% or more, or we have ICIQ score more than 16, or we have BLPP less than 60 centimeters or of water, we can use this intrauteral probe to enhance capability of urethral and sphincter strength. Maybe you can ask, how can this help? Because the major element here is urethral sphincter. But you should know that about 30% of collagen is based in the urethral mucosa. So when we retract collagen in urethra, we will add to the effect of vaginal laser. And also This was proved by Adrian Gaspar, where he showed that intraurethral laser reduced incontinence measured by ICIQ and also 1-hour PED test. Important thing is to act as soon as possible, not to wait for the lady who is leaking a lot unwillingly. So we have to act before through the generative phase of life, where we have better effects in reduction of incontinence. Of course, we will reduce incontinence in postmenopausal women, but the effect is better in premenopausal women. So if the lady is less than 47 years, if her body mass index is normal, if her ICIQ at baseline is 10 and less, and if her average birth weight of her offspring is more than 3.6 kilograms, she may expect that she will reduce incontinence for sure, at least for 30%, which is clinically good result. Next question is vaginal laser effective for overactive bladder? Let's see what the evidence says. This is a very exciting study, head-to-head study from our colleague Nobuo Okui from Japan, who produced head-to-head study between TOT and the laser treatment to reduce incontinence. And he used 1-hour PET test and ICIQ SF questionnaire. At the beginning, they were all on the start position. At the end of this study, they all reduced for the same manner incontinence, which means that laser, erbium YAG laser, produces effect which is the same as the gold standard to reduce incontinence. In the same study, Okui also analyzed how laser can affect overactive bladder problematic with urge incontinence. And he showed, which was normally and expected, that in TVT and TOT group, the symptoms worsened because of irritability after the implantation. But in erbium YAG laser, reduction was really marked, which means that this is a very good option because there are not side effects that are produced by TVT or TOT. Another exciting study for the same author, where he compared conservative methods, vaginal erbium YAG laser, anticholinergics, and beta-3 mimetics in reducing overactivity of bladder. And after 1 year follow-up, he showed the same, the reduction in all three groups, but the reduction in vaginal erbium laser was the only that was significant, which means that this is a very good method to reduce overactivity of bladder. What is the mode of the action? It is not only neocollagenesis, but also reactivating of the extracellular matrix synthesis and improvement of bladder vascularity, which will enhance trophism. Sexual life is deprived in women who suffer from incontinence. How can we help here? Marco showed us very well that we may use a laser in order to enhance the sexual gratification. And also we showed it here through another questionnaire 3 years ago in MS in Amsterdam, that through 12 months follow-up, we enhanced sexual gratification. This is not only for the incontinence, this is also because of better outlook. Here is a lady, you will see a few images before and after. So this is before, after first and second and third session. And you will agree with me that this situation, not only reducing the incontinence by laser, but this better look will enhance her sexual gratification. On the next slide, you will see how does it function. You will see on the left side, lady who is coughing before laser treatment, and on the right side, after. So please watch. So on the left side is before, and on the right side is after the treatment. So this is very effective treatment to reduce incontinence and also to reduce vaginal laxity. So I will repeat once again after this, Zdenko, that the laser in medicine is not, the laser are not the same. They are different because they radiate different energy at different wavelengths and produce different effects. Side effects are different. Drilling in some lasers and heating in erbium YAG laser. So adverse events are much less in erbium YAG laser. And what Zdenko showed also, they are only of cosmetic purpose, only vaginal discharge and transient edema, which will pass in few days. And we all announce these side effects to the ladies before the treatment. And I'm very proud to introduce you with the new Cochrane Library vaginal razors for treating stress urinary incontinence new protocol that implemented reference for our group in their protocol. So we are very proud of it. And shyly, but here it is, vaginal razor is coming in the recommendations of a lot of societies all over the world. This is from North American Menopause Society recommendation for usage of erbium YAG laser for GSM. We also mentioned that by the way is Italian Menopause Society first in Europe who recommended this erbium YAG laser treatment in these indications. So how to cope conservatively with the incontinence? Of course, but lifestyle change to stop smoking, stop overweighting, and to work up very, very frequently. And of course, a good add to this is a laser, erbium YAG laser, who supports that 10 years evidence that non-invasive erbium YAG smooth laser is very good option for treatment and is good in complementary medicine for stress urinary incontinence. So why not to use erbium YAG smooth laser? Thank you very much.
Thank you, Ivan. Thank you. Very well done. So we have time for discussion. Can you stop sharing, Ivan?
Yes. Yes, here it is.
I see the. Okay. There are some questions addressed to Dr. Gambacciani. One of our audience wants to know the follow-up, combined erbium follow-ups of the patients treated with combined erbium YAG and YAG therapy. I think he or she is asking for the superficial pain during intercourse, sexual intercourse. Do you have long-term follow-up?
Oh, thank you for the question, but unfortunately, I don't have a long-term follow-up with the combination of erbium and neodymium together, because we started a few months ago to start. We started 1 year ago with the both wavelength together for the superficial dyspareunia. But actually, I don't see any reason why the effects shouldn't last like with the erbium alone. And also, we do have the experience in the aesthetics when women, they are repeating neodymium treatments for aesthetic reason every year. And therefore, actually, I suppose, I don't have data, that the effects of neodymium on the vulva are lasting at least 6 up to 12 months. But we'll see in the future. This is one of the tasks that Vela has to cover.
Related with this question, Marco, I want to ask you another one. Did you have you tried to treat the patients, young patients, especially young cancer patients, to improve their sexual life? Because we have a lot of young patients treated with radiotherapy or chemotherapy, and their vagina looks very atrophic during the vaginal examination, and some of them, they don't want to use, they are very reluctant to use estrogen or any other kinds of treatment. So did you use them, erbium YAG laser treatment at all?
Yeah.
Do you have experience?
We did study a group of breast cancer patients. The youngest, she was 37. And we published the data on menopause back in 2015, and showing that we can get the similar results than with the postmenopausal women. And also those data I reported tonight on sexuality. The first data on sexuality I reported were obtained in some 25 women that were breast cancer survivors. So definitely also the breast cancer survivors, even if they are treated with GnRH agonist or aromatase inhibitors or the combination of two, they are responding to the erbium YAG laser. Maybe the most you need in some women not 2 or 3 treatments, but you need 4 or 5 treatments, mainly for the superficial dyspareunia, where the collagen synthesis is really jeopardized by the hormonal treatments. And for that reason, I suppose that the combination of erbium and neodymium are of help. But definitely we did obtain the results also with erbium alone.
I had a patient which is operated because of cervical cancer, and she received radiotherapy, vaginal radiotherapy, and after that I treated 3 courses of vaginal erbium intimalase, and I got wonderful response.
That's
wonderful response.
Also in patients, if I may, Tamer, also in patients that they got the radiotherapy for colon rectal cancers. Yep. For colon rectal cancers, the results with the vaginal erbium laser are astonishing, beautiful data.
Yes. One question for Dr. Fistonic, Ivan. Our audience is asking if you use estriol cream between laser sessions.
Generally not, because the effect of the laser is not only retracting the collagen, but also dilation of capillaries, which will produce better trophism and will produce better lubrication. So I do not need to use estriol cream during our treatments. But I would also like to add on the last thing that you raised, that we should stress really that gynecological cancers are not the obstacle for laser treatment. Am I right?
Yes, yes, for me. What is your comment, Zdenko?
You mean regarding the contraindication?
Yeah.
Well, in fact, we have a list of contraindications. Some are absolute, some are relative, which are left to you doctors to decide. But in fact, there is no obstacles to treat patients. The only issue is that as there were no studies done on this kind of patients, if anything happened with the patient who was before having cancer and then he was, let's say, healed either by surgery or however else, and after laser treatment through some time, some cancer came back, this patient can claim that this is because of laser, although without evidence. Mm-hmm. So this is one precaution which you have to be aware of, that this patient can be delicate in this sense. So if you decide to treat anyhow, please get a consent by this patient, explaining all the possibilities that they will not come after 5 years and said, because of your laser, I get cancer back.
Would you like to comment on use of estriol cream or estrogens before the treatment of genitourinary syndrome of menopause? Would you like to comment on the use of estrogen cream before the erbium YAG laser treatment, Zdenko?
Well, as you remember from the first study, which was published by Dr. Adrian Gaspar about the GSM treated by laser, he was doing a kind of preparation of patients for 2 weeks with estriol to prepare the very atrophic mucosa to a little bit better situation before entering with the speculum. So these two things are not excluding one another. Of course, it's up to patient, but this kind of preparation could be, let's say, helpful in a sense that these very severe cases of atrophy easier, let's say, survive the laser treatment, installation of speculum. But after our introduction of glass speculums, which are much gentler, I don't see really the need. And as I know, not really many people are doing this kind of preparations. You can tell by yourself, or maybe Marco and Ivan, are you doing these preparations or not?
No, I said I'm not doing this because we have here results from the breast cancer patients that are not allowed to use anything, and we have the same effect. Am I right,
Okay,
Marco?
but
Yeah.
I believe discussion was broader population, not just breast cancer. So
Yeah. But on the other hand, the Ivan data show that premenopausal women are having a better response in terms of urinary incontinence than postmenopausal one. So it means that estrogen may help the effects of erbium laser, at least in collagen remodeling. On the other hand, the estrogen improve collagen and improve collagen remodeling. And therefore, in severe cases, as I said, an integrated approach with the erbium laser in the middle, with that is in my mind today is the leader for the rapid improvement of vaginal atrophy. But it can be of help also to treat the women with hyaluronic acids or vaginal estriol or whatever, if the conditions are very severe, as you said. And they are not in conflict. They can help each other.
Mm-hmm.
Ivan, I would like to ask you, in your opinion, is it necessary to do some sophisticated investigation, urodynamic investigation, to establish the diagnosis of ICD before starting to do intraureteral erbium YAG laser?
I mean, this is a good option to undergo these studies because you will find out what was alpha leak point pressure here. And if it is less than 60 millimeters of water, you will easily go on with the procedure. But on the other hand, we have it has been proven that if you are dealing with severe incontinence where ICIQ score is more than 16, then you can easily use it. So in this case, urodynamic investigation is an option, but not in the very well situation of stress urinary incontinence where the lady coughs and I don't know.
Okay. And what do you say, Zdenko?
Yeah, I just wanted to add a comment. So through time, through these 10 years, we came to some kind of suggestion that we would treat both ways every patient with incontinence, especially the older one. Because as you well know, the atrophy of sphincter is happening to any lady. So it is always combination. It's never the clear situation, just let's say stress urinary incontinence of genuine type due to hypermobility, but there is always also a sphincteric component. And this sphincteric component is growing through the time. As we can see in GSM patients, there is always this urinary component. So our suggestion is to use both in these older patients, you can do even in the same session, do firstly intraureterally and then intravaginally. And in fact, we are now running the study in Canada. It's a multicentric randomized controlled trial where we have 3 groups of patients. One is treated just intravaginally, the other with just intraureterally, and the third with both. I hope next year the study will be finished and we will see the influence of intraureteral treatment. So far, whoever of our users were using it is quite happy with great results and with practically no side effects. And just to add, if you treat patients just intravaginally and you have some non-responders, as Ivan said, let's say 10-15% of patients, you can treat them intraureterally just to see if maybe you missed ISD because you didn't do urodynamics.
Yeah.
Urodynamics is expensive and unpleasant for the patient. So a lot of doctors our users will not do urodynamics. But in this way, when they treat just intravaginally and there is no improvement, if they then treat intraureterally, they can get significant improvement if the ISD was the issue.
And there is another question to the contributors. Do you prescribe any vitamins or supplements like vitamin C for laser treatments in order to support the collagen synthesis? Do you have any experience? Yeah, yes.
Marco was first. He wanted to
Okay, Marco.
I usually prescribe, sorry for my dog.
Oh.
I usually prescribe estrogens in severe cases, when I can. When I can prescribe estrogens, I do prescribe estrogen locally or generally. And I will prescribe the hyaluronic acid suppositories. I know that Ivan Gaspar is always prescribing vitamins and supplements in post-menopausal patients. This is not my common way of doing.
There is another question. Sorry, Ivan. I didn't get your answer.
In this case, I do prescribe something which will enhance vaginal flora. Like lactobacillus or something like that, because you will have a whole situation on a higher level if you have right pH in vagina. So why not?
And one question about the urethral prolapse. Do you treat the urethral prolapse? Do you have any experience? The prolapse, urethral prolapse treatment by erbium YAG laser. I have no experience actually by myself. Do you have any experience, Zdenko, Marco?
No, I don't. I don't have
urethral prolapse.
I must say that we got a few questions about this from some users, but as you all 3 don't have experiences, I didn't find anyone who was treating it. So to be honest, we don't have answer in this moment.
Okay. And you mentioned about treatment of recurrent urinary infection by erbium YAG laser. Would you explain us the mechanism behind the treatment, Zdenko?
Well, I think it's the heat working on these organisms like fungi or bacteria. In aesthetic, in dermatology, we have a treatment for onychomycosis with Nd:YAG laser, which we are increasing the heat under the nail. And we are pushing this fungi into the apoptosis, in fact, because we are not increasing the heat to the killing level, because it will be too difficult for patients as well. So we just increase to 45 degrees centigrade. And if you do this like a thermal shocking of this fungi several times, which means several sessions, they found this, let's say, surrounding unpleasant, and they go to apoptosis. It was proven through histological, mycological findings under the nails and so on. So I believe this is the same effect of the heating with superficial heating with erbium on vaginal wall, where these fungi are sitting. And this thermal effect is actually causing the apoptosis of them. This is what we found from the other field, but it also applies for this application, I believe.
Okay.
Doctor, just maybe a comment. Dr. Gaspar presented, it was not published yet, but he presented a 1-year follow-up on patients with candidiasis, where he achieved a very nice clearance of practically all patients. And he also did in vitro irradiation of these fungi colonies on agar. He irradiated them with erbium laser with the same settings as he's using in vagina. And he showed the decrease of these colonies after irradiation.
Okay.
So Zdenko, so he used the same settings as we use for, let's say, intimal ace or something?
I don't know by heart, but it is very similar. And the thing is that you have to irradiate the full vaginal canal, including the fundus or fornix, because when we treat atrophy or incontinence, we do circumferential and we put emphasis on anterior wall because we are going after connective tissue. But here, when you have this microbiota, you have to treat the full, whatever you can see, because if you have some pockets and they can hide, then of course you didn't do a proper job. So
you are
this
not,
is a difference, that you have to treat everything.
so you are not doing that blindly as we do these procedures. You have to dilate by speculum and then.
Well, I believe he do this in 2 steps. The first step is to do circular as we usually do, because this is the majority. It would be like 90% of surface. And after that, of course, to go and shoot down to the fundus.
To the fornix.
Fornix.
And there is another question for Marco. For the introitus pain, superficial pain, do you use PRP?
No, I don't have experience with the PRP. I know that some colleagues they are using PRPs for vulvar problems for lichen, for example. They are using PRPs. I don't have experience with PRPs, and it's an option. I cannot say anything more because I don't have experience on that.
Zdenko, would you like to comment on it?
Yes, I can comment that some people use it even regularly for atrophic situation, not only on superficial dyspareunia, but also intravaginally. For example, Dr. Gaspar is doing these injections in 4 lines along the vaginal canal, separated by 1.5 centimeters, small injections of PRP. Of course, we don't have yet a study which will confirm the contribution. So people knows about positive effects of PRP from other fields, and they assume it is same here. I also assume this. You even have now some producers which are producing like vaginal PRPs or hyaluronic acids to improve some indications without energy-based devices, just using these. But again, it has to be better supported by evidence.
Okay, so we are, our time is running out. So I think
maybe just one comment, Tamer.
Yes, please, yes.
Maybe you were not looking into the chat, but there is one question in the chat or comment in the chat, and maybe I can answer to it. There is Dr. Cecile Gunay. She was asking about G-Runner. She's a user of G-Runner, but she said she cannot find any studies done with G-Runner or comparing studies, disadvantages and so on. So maybe I can answer because we initiated several studies with G-Runner, and they were done. One was done with the stress urinary incontinence. It was presented on ICS Congress several years ago by the team from Mendoza in Argentina, and it will be published. So it shows a comparable improvement and excellent results in reduction of stress urinary incontinence. The other study was done by Dr. Gaviria when he was in Spain, and this study was about all 3 or 4 indications for smooth mode. So he was treating ladies with laxity, with incontinence, and the GSM with the G-Runner, and also had good results. For our users who are registered to LAHA web pages, you can check on LAHA lectures, And there are webinars. There are webinars about use of Genitourinary in these indications. You can find it there. We are looking forward to publish these two studies soon.
Okay, thank you, Zdenko. Before closing this session, I would like to remind the audience that they will find the webinar in website of Turkish Menopause and Osteoporosis Society. So I would like to deeply thank you, all of you, for your contributions. I really appreciate your contributions. Thank you very much, and hope you hope you be in well health because of Corona.
Thank you
Thank
for
you
the
very much.
invitation. Bye-bye.
Thank you.
Thank you, Tamer. Thank you.
Thank you, Tamer.
Bye-bye.
Thank you.
Bye-bye to
Ciao,
everyone.
ciao.
Bye.
Bye.